Yeah.
So hello everybody, a warm welcome and good evening to all. Rural Service Bootcamp is back with another edition this Sunday on common dermatological conditions seen in rural service. Today, the session will be presented by Dr. Navneeta Vani from the batch of 2016. She has completed her rural service from Emmaus Swiss Leprosy Hospital, which catered mostly to the dermat needs of the population, and she saw a footfall of around 200 OPD patients per day, most of which came with dermatological conditions. Hence, she's quite adept at answering most of your questions dermatologically related. Currently, she works as a JR in the Critical Care Medicine Department of St. John's. Our moderator will be Dr. Mihika Narona from the batch of 2011. She did her rural service from Tiruvallur, Tamil Nadu, and has completed her post-graduation in Dermat from St. John. She currently works as an SR in KMC Manipal, and she has always shown great enthusiasm in teaching all of us and clearing all of our doubts, no matter how silly it might be. And she also, when I was an intern, I remember how much she prepped me to like know what to do for common dermatological conditions. So I'm very privileged to have both of them to be taking the session today. So thank you. A few reminders, please keep yourself muted throughout the meeting. If you have a query, please type it in the chat box or join at Academic WhatsApp group. And a feedback form will also be shared on both the above platforms. Please fill it in before leaving the meeting. Now over to Dr. Navneeta.
Hi, a very warm good evening to everyone. Thank you so much, Tara, for that wonderful introduction. Let me just share my screen. Is my screen visible?
Yes, yes.
Yeah. So let's start. So as Tara mentioned, today we are going to be discussing common dermatological conditions seen in general OPD. We'll be concentrating on the practical aspect of it, how the patient is going to present to you, how are you going to diagnose it, what treatment are you going to give them, what advice are you going to give them, and when are you asking them to review back. First slide would be regarding a common, I think someone is unmuted themselves because I can hear my own voice. Thank you. So these are some of the common ointments one center would be having. Even if that center is do not have any other dermatology related ointment, but they would definitely have something like this. That is an ointment which has multiple, it's a combination ointment of multiple things. There will be an antifungal, antibacterial, anti-inflammatory, and a steroid in it. So our main aim of this class would be, after this class, we'd be really happy if you do not have to use any of these. Because you would know which exact drug or ointment to use for a particular disease, not a combination ointment which is not specifically for a particular disease. So that would be the aim for our class today. So I would ask you to just put it in the chat box, what disease is this? So the patient is presented with itching for around 2 weeks, started initially on one area and then spread to other areas. The patient also is saying that some of the family members also having the same symptoms. So what do you think the patient is having? I cannot see the chat box, so someone has to tell me what they are answering.
Yeah.
Dwani
said Tinea corporis. Anyone else? So I know this is pretty common. Most people come up to me and tell me, and this includes my batchmates and people I've known for years, that everything in dermat looks the same. So that's why we don't know what to do. So one habit I want you all to inculcate is to learn to properly describe what you're seeing. If you repeat that single explanation day in and day out to yourself, every time you see that patient, you make that description, automatically the connection in your mind will go, because it's very pictorial. Dermat is very pictorial. So unless you associate those words with the image, you will not get your diagnosis. So over here, if you look, there are annular, scaly plaques, most of which are showing central clearing. Okay, and there are various distributions. One is on the face, there is on the trunk, there is on the legs. So this tells you it can be present everywhere. Usually this starts on the flexures. So Dhwani is right. This is Tinea corporis.
Yeah,
And
very good.
fascia
Thank you
also.
so much.
Yeah.
Yeah.
So Navneeta, I think you can go ahead.
Yeah, like Dr. Mika said, you have to see the lesion. Whenever a patient comes to you telling that there is itching, they would be reluctant to show you, because in case of tinea, it will be in the groin area or the buttocks or in between the creases. So they feel shy to show you. If it is a female doctor, the male patients, vice versa. So, but you have to tell them that you have to at least, even if you know for sure, yeah, there is another lesion on the face and which is tinea, and you should not assume that the patient is gonna have the same lesion in the groin as well. You should make sure that you see all the lesion, because you then only will know whether it is the same problem or something else. You have to always tell them that I know it might be the same issue, but I just want to take a look at it so that I know how much to give. Should I give something else? Should I give like two tubes or one tube? Just tell them the explanation and they'll be more than happy to come inside the curtain and show the lesion to you. So always make sure that you see where all the lesion is there. Like what Dwayne said, it is tinea. There is fascia also and corporis. Let's see what those terminologies mean. So tinea corporis, cruris, fascia or PDs means it is fungal infection which is on different parts of the body. Corporis means any part of the body. Cruris means in the groin, fascia means on the face, pedis means on the foot. So presenting complaint would be itching. Main complaint would be itching. They will have so much itching that they're not able to sleep and not able to work and all of that. The blackish discoloration will be there. There'll be raised scaly edges, which is giving them a ring-shaped appearance with central clearing. So you have to examine hyperpigmented scaly plaques you're seeing with raised borders and central clearing. If they have used steroid before, they would have. Mostly they would have, because either they would have used it as one of those combination ointments which I showed you earlier, or when they'll go to a medical store and ask for an ointment for itching, and they would be given a steroid ointment. So they would have used like that as well. So then it will be presented as concentric rings. We'll see why it is coming like that later. The common locations are flexures. It might not always present typically because of all these other reasons. They must have used something else on top of it. There would be an added bacterial infection on it, things like that. Investigation of choice would be a KOH test. All centers would not be having, but if you have and you are having a doubt whether it is a fungal infection or not, you can definitely go for a KOH test. Now, what is Tinea capitis? It is tinea infection on the head. Presenting complaint would be patchy hair loss with itching. So if there is a hair loss, and most commonly presented among children, if there is hair loss, you have to go and examine. Ask them whether there is itching or not. Ask them when it started. Did they go to any barber, new barber, or get their head shaved? Did the barber clean the blade and things like that? You have to ask those questions, because there will be itching. If there is no itching, we can think of other causes as well. But if it's a child with hair loss and there is itching, you have to think of tinea capitis. When you're closely examining, you can see that they are circular, they're itchy with gray patches, broken hair shaft will be present, or there will be black itchy dots. Someone has unmuted. I can hear my own voice again.
So
And
one
everyone
thing
can
that I
hear me?
want,
Yeah.
one thing that I want you all to know is you need two things in a clinic where you're seeing dermatology. One is a torch, and the second thing is a magnifying glass. So a lot of people say, I don't know, I'm not sure if there are black dots. You're not sure because you're not using a magnifying glass. 6x6 vision, not enough in dermat. We in fact use higher magnifications in our OPD. We use something called a dermoscope. But the least you can do in bond is to carry one magnifying glass and a torch. The torch will give you two things. One is it will tell you whether the border is raised or not. And the way to do that is to shine the torch tangentially onto the surface. So very often when you're not sure if it's patch or plaque and I get message, ma'am, I don't know what it is, the raised lesion, when you shine the torch, will become very obvious. And those dots you will only see if you use the magnifying glass. Standing this here and keeping a patient on the other side of the table, you're not going to be able to find anything. Get up, it's good for your health. Continue, Navneeta.
Yeah. Okay. So now let's look at some pictures. You can see on the top two pictures is different from the bottom two, right? But everything is fungal infection. So let's see what is the difference.
One
On the
second.
top right, yeah.
Navneeta, 1 second. I can
Yes.
see people in the chat box. So I want you all, in your own language, to describe the bottom two lesions while Navneeta describes the top two lesions. I'm not judging y'all. I just want to know how y'all describe lesions so that we know where to start from while guiding y'all. Navneeta, go ahead and describe the top two lesions. In the chat box, just put how you would describe the bottom two lesions.
Okay. In the top right corner, you can see that there are patchy hair loss, obvious patchy hair loss, but from here itself in such a, it is not a zoomed in shot and it's not very clear, but still you can see those short hair shafts, broken hair pieces in between those patchy areas, right? In history would give an itchy patchy history. On the left side, you can see that very clearly raised plaques, scaly plaques with irregular borders, which is spread throughout the head. But because the patient has shaved the head, we cannot see an alopecia patch, but there is obvious raised plaques with scaliness. Okay.
Amal, can you describe the picture here, picture C, that large round lesion which you see? If you at least tell me what's missing in that picture, which is supposed to be on the normal scalp, I'll be happy. Dhwani? If you all want and you all prefer, you all can unmute and tell us.
The C picture, there is like hyperpigmentation of the skin and there are no hair follicles that I can see.
Yeah, so it's a well-defined plaque with loss of hair. There is also scaling. Navneeta, give the full description. When you're right.
Here yes. So in the C picture, you can see that it's a large, boggy, edematous swelling. Since it's a picture, you're not able to differentiate whether it's a raised plaque or a patch, but it is a swelling actually with pustules studded on it. Here, is my pointer visible?
Visible.
No, visible.
It's
No, you can see those small pustular spots. It's not very clear, but it is present. So this is what we call as chirion. This is also a fungal infection, but an inflamed version of it. It is because of another strain of fungus which is getting infected. Treatment would be same as Tinea capitis, but if you are suspecting another additional bacterial infection on it, then you have to treat the bacterial infection as well. Then the D picture, Mihika, you want to ask anyone to describe it first?
sure. Can we have Stephen Raj Gomez? You can unmute your mic and just describe. It doesn't have to be right or wrong. If you make mistakes also, it's fine. The point is to make the mistake here and not with your patient. Stephen Raj?
Yeah, so that appears to be a kind of some kind of alopecia on the back of the head with crusting and associated inflammation of the skin because there's some redness.
That's spot on. So there is alopecia, which is loss of hair. You are also seeing thick adherence scaling. So this, in dermat terms, is called a scutellum. But if the fact that you identified there is this thick adherence scaling, there is loss of hair, and there is inflammation, will give you your diagnosis. Navneeta, the diagnosis
would be flavus. So this is also a fungal infection with crust, like what he said. If they are very adherent, you will not be able to remove them that easily. So you have to cut the shafts around the lesions and do the antifungal treatment. Then it will work effectively. Now, this is another type of fungal infection. There is a difference. If you can point out the difference between this lesion and not the Tinea capitis one, the normal Tinea corporis, the normal Tinea corporis with this one, that will be more than enough.
Smita Parmar. Smita, what is unusual about this lesion? What are you seeing? Smita, are you in the meeting? Okay,
If you're
Irene?
not able to see the difference, that's also okay. You can just say you're
Yeah,
not
just say
able
I don't
to.
know. Say I
Yeah.
don't know. It's fine.
That is also fine. We are here to
Irene?
learn.
There are two circles, a ring. It's ring
It's
shaped.
like ringworms. Yeah.
Yeah, so there are multiple rings. That is a very astute observation. In the initial pictures, if you saw, there was a single ring. Navneeta, why does this happen?
So what is this? What we call this is Tinea pseudoimbricata. That is steroid modified tinea. Because of the use of steroid, what happened is that there is a central clearing. Because a patient's immunity has been suppressed in the area in which they have applied the steroid, because of which the fungus spreads multidirectionally, bidirectionally, because of which they will spread towards the periphery and give the ring-shaped appearance.
So typically what happens is you have the fungus. It will start in the center. Then your host immunity will come in. It will clear it from there. The fungal hyphae will spread outwards, which is why you call it ringworm, and there's a single ring. Now, if you've used a steroid cream, what happens is, yes, the immunity has kicked in, it's cleared it off a bit, but that immune response is not sustained because of the steroid. So the fungus grows back inside, and then you get these multiple concentric rings, kind of like a rangoli pattern. So if you see this is a very good indication. If patient comes, I don't know, I applied something, I don't know what I applied. What they've applied is a steroid. Other things that can tell you that the patient has applied a steroid is the skin appears very thinned out, and you can see stretch marks or striae. Go ahead, Navneeta.
Yeah. Thank you.
Yeah,
So
once
let's
again,
go to
I have a doubt about that. So just to clarify, I mean, I guess that this doesn't really matter on presentation, but the first ring that that appears is the outer ring, and the inner ring is the one that comes new, or is it the other way around?
So normally you'll have the inner ring, and then it will keep expanding in size. The diameter of the ring will just expand in size in a typical case of tinea. Now what happens is now you'll have the outer ring, and that keeps growing, and then you get concentric rings appearing inner to that as the outer ring keeps expanding.
Got it. Okay, thanks.
Okay, now let's move on to the treatment. The first one was how the patient presented. Then we identified it. Now we have to give them a treatment. Main important thing here is the hygiene advice. Tell them that this is not going to go just with the treatment that you're going to provide them. They also play a huge part here. They have to bath twice a day. Does not matter if it's cold, hot, or whatever. They have to. Please ask them not to share towels, soaps, or any other clothing material, because they tend to do it in rural areas to share. It is very common for them to share towels. They do not have one towel which is just for themselves. It will be common for the entire household. To tell them that it will spread to your children. The treatment cost is going to increase. It is going to be difficult for you. So please don't do that. Make sure first thing that you go back and do is buy a new soap and towel for yourself and keep it separately from the rest of the family. Keep your nail shots. The thing is that they will scratch in one area, and tell them that if you touch another person with the same hand, that is going to spread to the next person. So they have to keep their nail shots. Please ask them not to scratch those areas too much and touch here and there. Ask them to wear loose cotton clothes. Cotton clothes will really help. Ask them not to wear anything synthetic until we finish the treatment, and later on as well, if they can. And then wash clothes after a single use, even if it's the jackets or the burqas that they wear outside. This is very, very important. Stress upon this. Tell them how important it is for them to follow these instructions. Next, we would go to the treatment that we are going to prescribe and give them. So we'll be giving them antihistamines. We'll give them topical and oral antifungals as well. Antihistamines, what all you can give. Whatever you have in your hospital, you can give. Cetirizine in the night, Allegra probably. If they have itching in the morning as well, they're not able to go to work, or they're having difficulties during the daytime, you can give them Allegra in the morning. But when you're giving an antihistamine, tell them that there is a side effect that they might feel sleepy and all of that. So if they have work in the night and things like that, they can adjust accordingly. The topicals. Topicals, there are multiple choices that you can choose from. Whichever is available in your center, you can choose. Terbinafine ointment, ketoconazole, luliconazole. But if the patient is having financial constraints, cheapest topical azole would be miconazole ointment. That has to be applied twice, morning and night. for 1 to 2 months. So we have asked them to bath also twice, right? What usually they do it for them, a skincare or a thing that we have to apply on the skin is to be applied for some time and then take a bath. That is how they usually think of it. So tell them specifically that you have to apply these ointments after you have taken a bath, because some patients specifically ask you, how much time should I keep it before I wash it off? It's not like that. You have to tell them you have to take a bath, apply the ointment and leave it. So it's always after bath. Specify on that as well. Next, we will go to the oral treatment, oral antifungal. This is the ITAR guidelines. Itraconazole would be 100 mg, 1 to 2 capsules, a single
One
time
second.
for 3 weeks. Yeah.
1 second, Navneeta, before you go ahead. So now common complaint that I have is that you all don't have time. Like I'm sure Navneeta, when she had 200 patients a day, explaining all of this was tedious. You have to remember, when you're working in a bond center or even if you're working in the hospital, you are not the only person working there. There will be 200, 300 other people sitting in your center whose job is not as intense. You can train people to do the counseling part for you. So you can ask them to even sit them down in groups of 5 or 10, because tinea comes in like by the dozen. And groups of 5, explain to them all these other general measures rather than you sitting and tiring yourself out with each one. So you can write the treatment. The counseling part of it, you can train someone to do.
Thank you so much, Milka, for bringing that up. Actually, it's a very good point. Like what Milka said, we used to get a lot of patients. How we used to handle is, the sisters and the aid helpers, all of them knew how to advise tinea patients. So if one family member comes, the immediate question that we would ask is anyone in the family having the same problem? If they have, we will call all of them together instead of calling each one separately. So we can counsel all of them together. And next thing, if we have a lot of people at a time, I would give them the prescription after they have got the counseling from the nurse or the aide which is there. So that is very, very helpful in case of tinea and scabies and all of that, which is going to be common, but which affects a lot of people together. Okay. So coming to the oral itraconazole, you can give 100 mg, 1 to 2 capsules, OD, 1 time a day for 3 weeks. You are giving it for 3 weeks. Tell them that it might reduce within the first week of starting the treatment itself. They will feel that what is the need for me to continue the treatment. They will stop the treatment. Tell them it is going to come back. So if they take it continuously for 3 weeks, also ask them to review back after 3 weeks, even if there is no lesion and no itching. And ask them, tell them that the lesion will subside within a week or so, but still you have to continue. It is a course. Otherwise, it's going to be difficult for them itself because they have to keep coming back again and again. Okay. Same with terbinafine. Yes.
If your patients don't understand, you explain to them tinea is like a tree. What they are seeing on the surface is the branch and the fruits, but there are roots that go right down. So even if they've chopped the tree, as long as the root is there, sometimes some trees regrow. So you have to make sure that that entire root system is dead of the plant before it comes back again.
Correct. We used to tell Olagada ide, Lopilundi. That is exactly how we used to describe those things, because they used to how come it came again, because we have already I have already had the treatment, but how come it came again? We always say the roots are still inside, so it will keep coming back. You have to kill it from inside. Okay, so terbinafine would be 250 mg per day. If it's terbinafine, it would be for 4 weeks. Griseofulvin would be 500 mg for 8 weeks. Fluconazole would be 50 to 100 mg per day for 4 weeks. So here, if there is a steroid abuse or anything before this, then the course will change. Tell them that it's going to take longer. Whatever period is written over here, ask them to review after that to make sure all the lesions have gone. If it is still there, you can continue the treatment and tell them to review back again. Okay. So that is regarding oral. Now for tinea capitis, you can give the topical and add a ketoconazole shampoo with it once a day. And since it is more commonly seen in children, the preferred one would be griseofulvin 10 to 20 mg per kg per day. Since you're giving antifungal, oral antifungals for alcoholics and long time, they would have already taken the treatment somewhere outside. So for those people who are already on long time antifungal treatment, you have to do a baseline LFT and triad and repeat it monthly. Okay. Now coming to the next disease.
1 second, Navneeta. So this
Yeah.
is something that we put in your quiz and a lot of you all got it wrong.
Yes.
Anusha, are you in the meeting? Anusha Jane Matthew. Can you describe the first lesion? If you don't know what it is, you can just straight up tell us also. No problem.
Yeah, can see macules and patches, hypopigmented macules and patches in the first one.
And then the second one?
They are hyperpigmented macules.
Excellent. Excellent. What I'm very proud of you is that you said hypopigmented. So that is the key word in clinching your diagnosis here. Navneeta, you can go ahead.
Yeah. So here the patient has come with a short history, 2-week history of these patches which appeared on the chest and the back, underarms, shoulder region, etc. What could it be? So this is Pityriasis versicolor. People have diagnosed this as vitiligo. Could be, right? I've only put the left picture. The right picture was not there in the quiz. Maybe because of that, people thought it was vitiligo. It is caused by Pityriasis
Navneeta,
versicolor.
why is it not vitiligo? Can you tell them why?
Yeah.
Even because
Yes,
patients do come with only the left side, right?
Yes. So here, first thing is the history. It's a very short history. They will come with 2-week, 3-week, maybe a month or two also. They would have left it because they do not have any other symptom other than these patch. People are really scared of hyperpigmented patch. Hyperpigmented lesions in the body. They also think it is vitiligo. They're very scared, especially when it is on female patients, female children and all of that. The parents get really worried and they bring it. When parents notice it, that's when they bring the child. The child would not have noticed it because it's on the back or someplace that the child can't see. And next would be the distribution. It's only over the chest or the axilla or the back where there is a lot of sweating happening. Not on extremities or hands or legs or anywhere. Okay. And the third would be via examination. When you're examining, you can see small scalings. If you're not even able to see the scaling also, just stretch the skin. Slightly stretch the skin and that time the scales will appear. So that is how you differentiate Pityriasis and vitiligo.
So pityriasis is basically a classical example of stigma in dermatology being transferred from one disease to another. So across communities throughout the world, there is a lot of stigma attached to leprosy. Now, leprosy presents with hypopigmented patches. Now, the difference between hypopigmented and depigmented not very clear to a lot of patients. When they see vitiligo, that stigma got transmitted to vitiligo as well. Vitiligo has no internal complications. It's just a loss of pigment. So it's never going to kill you. It's never going to have deformities. It's never going to have major issues. Yes, it is cosmetically unacceptable to a lot of people. It doesn't look that great. So people do seek treatment. But if you don't treat vitiligo, nothing will happen. But because of the stigma of leprosy being transmitted to vitiligo and from vitiligo transmitted to these other hypopigmented disorders, patients are very anxious. So the first thing you need to do with this patient is tell them, this is not vitiligo and this is not leprosy. And even it was vitiligo and it was leprosy, there are treatment options for that. Reassuring your patient is the first step of ensuring that your patient will continue to take treatment. Patient doesn't trust you. They're going to take treatment for 1-2 days, say it's not working, and then leave and go to the next place where someone will give them a steroid.
Okay, so pityriasis, tell them that it is also a fungal infection. It is caused by a species of Molluscum. Why is it happening? It is because of oil application. Even if they are putting a lot of oil on the head, it can come to the neck and back region along with sweat. So when it mixes together in humid, warm climates and all, it's very, very common. There will be sharply demarcated macules with fine scaling. So scaling is more apparent on scratching or stretching the skin, which is called a scratch sign. It is usually non-pruritic, or they might say slightly pruritic because of the sweat and things like that. They might say itching is also there. Okay. So what do you give them? So we give them ketoconazole stay-on lotion. Okay. A lot of you have soaps. Some people do ask for soap, but stay-on lotion would be much more preferable. And here also it will be after bath. It is not a lotion that you apply and keep for some time and wash off. You have to tell them that you have to apply it after bath. Okay, and then hygienic practices. Explain to them that you have to wear loose cotton clothes. You have to tell them sweating is the cause, so you have to take a bath after you have come back from work or school or whatever. And then topical azole creams, ketoconazole and luliconazole ointment also you can give, but a stay-on lotion would be preferred over an ointment. You have to give it
So
for 2 to
one
3
thing that
weeks.
I want you all to remember is an order of preference when you're treating a fungal infection. It's going to be lotion over cream over ointment, because ointments are more oil based, and we've established that having oily skin is one of the things that the fungus feeds on. It's basically nutrient for the fungus. So the drier your base is,
Skin.
your application base is, that is lotion, the better it is for your patient. The second thing is this will be more common in the peripubertal area, because that's the time when your sebaceous secretions increase. And other things that you can tell them is to avoid oily foods, to avoid highly processed foods, because that increases the sebaceous secretions, which predispose them to that. City, one of the common causes is they wear these synthetic clothes to go to the gym, and they keep re-wearing those synthetic clothes every time they go to the gym. So very often among people who gym out, you might see Pityriasis versicolor.
Yes. Okay. Now we'll move on to the next. Patient has come with streaks or linear bands, or it could be well circumscribed patch also of powdery white or yellow. In this case here, it's completely yellow, right? Yellow discoloration of the nail. There is no itching, no pain. History is a long history. It's been there for 6 months, maybe 1 year. I noticed it recently, and all of that. What is this? This is Onychomycosis or Tinea angum, which is fungal infection of the nails. Here also, counseling is a huge, very, very important thing, because this is going to take a long time. If so tell them that you have to come back and check with review regularly, but it is going to take 3 to 6 months or maybe more than that also. Okay, so you're going to give amorphine 5% nail lacquer. You're going to give it for local application twice a week. So when you're explaining something which has to be taken twice a week or just a week for a month and all of that, you tell them which day of the week you have to apply. So if you're telling, for example, Sunday you have to apply, because Sunday mostly they will be at home, so they will have time for applying. So tell them Sunday, and another day like Wednesday, which is like 2 days later, and next Sunday and Wednesday. So every Sunday and Wednesday for 3 months for fingernails and 6 months for toenails. So you can ask them to come back and review after a month. Review after a month. You can see how it is. If everything is fine, the patient is comfortable with the treatment, you can ask them to come back after 2 months, like that. Then you will give a tablet. Yes.
Dhwani has made a very valid point about using Whitefields ointment. Whitefields ointment is commonly used, but it should not be used in isolation. Whitefield ointment basically removes the top layer of scale and allows the penetration of your other drugs. So if you are having a lot of resistance, you can use Whitefield's ointment, but do combine it with another antifungal. It's not an isolated treatment. Otherwise, you'd have a lot of cases of relapse, because you're just like smoothing out the surface, but the hyphae are persisting underneath.
Yes, in my hospital also we used to use salicylic Whitfields, but we always used to mix it with another. We always used to ask them to mix it with another antifungal, and then give. Okay. So we're gonna give nail lacquer, and then with that the next treatment would be tablet itraconazole plus, which is 200 mg itraconazole. Before we gave 100 mg, this is 200 mg twice a day, morning and night for 1 week, a month. That is, if you're starting the treatment on 1st, tell them from 1st to 7th you have to take. Then you have to stop. So initially it's better to give them the treatment for a month and ask them to come back. If the patient, especially if you have to monitor the LFT and creat, you have to ask them to come back. Or else also to make sure the patient understood what you have told, and if the patient is comfortable with the treatment also, ask them to review back in a month and see how things are, and then give them treatment for another 2 more months and ask them to come and review. That would be the ideal situation. 3 months for fingernails and 6 months for toenails.
One thing I'd like to reiterate is all itraconazole brands are not the same. I'm all in favor of generic medicines for antihistamines, things like that. But itraconazole has a problem with bioavailability. So some of the cheaper drugs are not appropriately formulated, which is not an us problem. It's a government regulation problem, which they should take notice of, but unfortunately they don't. So please speak to a dermatologist, because I'm not going to recommend brands here, and find out what brands are available in your area, which are least expensive and which you can give to the population with good bioavailability, because all of them will not work the same. And this applies to very few drugs like biologicals. These, the brand makes a difference. For your regular antihistamines and stuff, it's not too bad. Most antihistamines do work without a problem.
Yes. And one more thing which I forgot to mention was that for tinea, when you're giving them an oral with a topical, make sure that you give two different groups. Like if you're giving a terbinafine ointment, you can give an azole as a tablet and otherwise. So that to make sure that we are covering it from all sides rather than giving the same type of oral and topical. So try to pair it up with two different groups.
This will target two different sites in your fungal cell wall synthesis. Therefore, even if there's a little bit of resistance on one side due to biofilm or some other reason, the other drug at least will be able to work.
Okay. And for pityriasis, please use only azoles, not other topicals. That is why I mentioned ketoconazole stay on lotion and topical azole cream. Okay, not any other cream, only azole. Next, coming to acne.
One
Yes.
second. Let's look at this. Sanil Karant. Sanil, are you in the meeting? Shailendu Singh. Is Shailendu here? Sister Princely, are you here? Angel Sunny. Angel, can you tell us what are these 4 grades? Angel? Am I audible? Namnita, can you hear me?
Yes.
Okay. Teres, Mridula Teres.
It's already
Mridula?
there. You can just read it out.
You
That's
have
also
to
fine.
read it.
Hello.
Yeah. Describe the lesions, no?
It's
on the slide.
Grades of acne vulgaris. Grade 1 is just comedones, and it could be whiteheads or blackheads, and with papules. And grade 2 to 3 it's mainly more of papules and pustules. And grade 4 is nodules and cystic. That's nodulocystic acne, grade 4.
Excellent. Namnita, go ahead with the treatment.
Yes. So this is going to be very common. All hospitals, irrespective of whether it is a dermatological place or not, you will definitely get acne. So it is very important to know the grades because the treatment differs. So depending on the grade, we treat the acne. So grade 1 would be just comedones. Comedones are basically clogged sebaceous outlet with keratotic material. So that's why it appears as black, which we commonly call as blackheads. So these are open comedones, and closed ones are the pilosebaceous opening will be closed, blocked beneath the skin. So it will appear as a hump rather than a black dot. So that are comedones. What are you going to give? Benzyl peroxide, you can choose 2.5% gel at night. So guys, I'm going to upload a document with the treatments of common dermatological conditions, so they do not have to take any notes. If I do not get a time to make a document like that, I'll upload the PPT directly in the discussion group. Okay. So benzyl peroxide 2.5% in the night, or adapalene gel, that also in the night, or 0.025% tretinoin in the night. You have to give it for a month. Since it's a recurring thing, you can ask them to apply it. When you're giving adapalene and tretinoin, make sure you tell them, even if it's there in multiple areas, ask them to apply it locally, not entire face. They tend to apply it on entire face, thinking that will prevent new pimples from appearing. So make sure you tell them to not apply a lot because it will burn your skin.
So the amount that we describe is a pea-sized amount. Both cheeks, forehead, and chin. These are the areas where you have to apply. They do have a preventive action. The retinoids do have a preventive action. But I personally, in my bond center, used to prefer not to use retinoids. As a dermat, I do use retinoids more because I'm a little cautious in a rural population because most of them have sun exposure. So they have severe irritant reactants even if they apply it in the night. When they go out in the day, they have a lot of skin irritation and sunscreens become quite unaffordable for this population. So in rural areas, I used to prefer benzoyl peroxide, 2.5 up to 5% is also available. And if they're not tolerating, one simple method is something called short contact. So you tell them to apply it for 30 seconds to maybe 5 minutes, as much as they're tolerating, and then you can, this is one of the things that you can wash off.
Yes. And also you have to be very cautious with female patients. Ask them if they're planning pregnancy or planning to get married soon. Because even topical retinoids you cannot give during pregnancy. So tell them that before giving the treatment itself. Even if they do not have any plans of getting married, tell them because they tend to reuse the same treatment. If you give one treatment for acne, they might not come back to you the next time they get acne. They might continue whatever treatment you have given previously. So that's why just before giving retinoids to any female patient, just tell them this. Now, grade 2 to 3, that is papulopustular. You have to give topicals, that is benzoyl peroxide or tretinoin, like I mentioned before. Along with that, morning you're going to add clindamycin gel as well because there is pustules also here. And with topicals, you're going to add capsule doxycycline 100 mg once a day for a month. Yes, you have to give continuously for a month. Ask them to review after a month. Okay.
So the general treatment for acne can go up to 6 months. So initially, if they come in with grade 2 or 3, you start doxycycline. Doxycycline can be given to up to 3 months till you are sure that the patient is in remission. Then you take off the doxycycline, maintain on your topicals. Continue the topicals for another 3 to 6 months. Some patients who are like 16, 17 years old, you might have to keep them on the topical treatment for a few years. So don't like tell them that, this is not one of those things where you treat like, patient has upper respiratory tract infection and you treat for 5 days and they're fine. This is something that will recur and can recur, especially in the adolescent age group. So other things also will need to be addressed, telling them not to eat processed foods, avoidance of dairy. These two are very important things to counsel your patients about. Because their mothers will be like pouring glasses of milk down their throat saying this is your growing age. And that is like a significant contributor to your stage 4 or nodular cystic acne. So no dairy. And food-wise, no processed foods. So kurkure, chips, instant noodles, these are things that tend to worsen your incidence of acne. Nodular cystic acne, I don't want you all treating. Please do not treat it. The reason being isotretinoin is licensed to be prescribed by a dermatologist only, like no other specialty. If you're stuck in the middle of nowhere, please do it in consultation with one of us. Medico-legally, you write isotretinoin, that lady goes and gets pregnant, you are in massive soup.
Okay, so nodular cystic, you're going to refer. Now, you're going to see acne along the jawline. She's a 15-year-old girl, and there are some symptoms of hirsutism as well. Then you have to suspect PCOS and tell the child to get evaluated. If you have the necessary tests in your hospital, get it done. Explain why this is happening. There is a chance of ask the girl child about her periods. Is it regular? Are you having any other difficulties and things like that? And tell that there is a high chance the child is having PCOS and get the child evaluated. Okay.
Okay, Namrita, before you go ahead, Dhwani wants to know, are there any hygiene-related things to counsel our patients like changing pillowcases, face wash, number of times? We typically tell our patients to wash their face twice daily, once in the morning, once in the night, prior to the application. Do not overwash. When you overwash, the face becomes dry and in response, it tries to produce more secretions. That tends to worsen the acne. You do not have to prescribe a specific face wash, but you can use certain salicylic ones. There is an increasing trend of people using these over-the-counter. I'm not going to take company names, but you'll know what I'm talking about. You'll see the ads on Instagram. those have suboptimal, sub-prescription doses of salicylic acids and retinoids and all. The problem with that is the patient becomes desensitized to the effective prescription drugs and they require much higher concentration for treatment later. Do not sub-optimize your dose of treatment. No matter how nice that med rep is who visits you, your primary concern is treating your patient. One thing that you can tell them is to not use soap on their face. You can use a Syndet, which is a synthetic detergent. Common ones that we tell people to use are something like Dove or Cetaphil. That takes away the thing. There are formulations meant for dry or oily skin. So look at your patients. People with dry skin, atopic dermatitis can also get acne. In that case, if you see both these features, please talk to one of us and see which one is fitting into that particular patient's budget that we can prescribe at that stage. Don't recommend these OTC ones. General hygiene has to be maintained. Pillow covers should be changed. Ideally, if the patient is once a week. Another thing that I find is mobile phones. Please ask your patients to clean their phones. You'll very often see one side of the acne being worse than the other side because they're holding the phone on that side.
Okay. Next would be Molluscum contagiosum. So it is caused by MCV1 majority or MCV2 in usually adults and HIV related cases. The typical presentation would be what is shown in the picture, that is shiny, pearly, white, hemispherical, umbilicated papules with central core. Commonly seen with 2 to 5 years of age. If you're seeing in adults, you have to suspect some sort of immunosuppression. If they're already having some sort of immunosuppression, still check if they've got evaluated properly for everything. If not, get them evaluated. Tell how important it is for them to get evaluated. Okay, now how does it present in children? It's gonna be very, if you do not see, here also examination matters a lot. If you don't examine properly, you're gonna think it's a small pimple. It's just a papule. You might not see the umbilication and things like that if you don't shine a torch and go closely and observe. But please don't touch or examine it too much, because it might spread as well, right? So it's going to be one papule or two, like what is shown in the middle picture. There are only 3. That's it. The child might not have any other symptoms, itching or pain or nothing like that. It might be around the lips or wherever. In the right corner, you can see there is additional bacterial infection also, because the child might have scratched on it or something like that. So the
Please
treatment
do not touch any dermat patient, regardless of what you think the diagnosis is, without gloves. Actually, do not touch any patient, period, without gloves, because hepatitis B, C, these things, small cuts on your hand, you don't want to pick those things up. We are not routinely screening all your patients. Very often, people have examined patients with chickenpox and then called me in panic after that. After that, I can't do anything for you. At the most, we can do a little bit of maybe prophylaxis or something. That is quite expensive. Varicella IG is quite expensive. You don't want to be taking prophylaxis. Do not touch any patients without gloves. That's a standard rule. Wash your hands after every patient. Both these things, everyone, please. No point panicking later that patient had chickenpox, patient had something else.
Yes. So usually, since it's a child, tell the parents that no need to panic. It will spontaneously resolve within 6 to 9 months. Please tell them, ask the child not to touch it or pick on it or scratch. It will spread. You can give treatments like curettage and cryotherapy. Curettage is very easy to do, but if you are not sure how to do it, we would not recommend you to do it in your rural hospital. Another option that you can give them is topical 10% KOH. You can tell the mothers to apply it using a toothpick in the night until there is inflammation or ulceration on it, and later on the molluscum will clear.
One correction here, Namnita, it's twice daily, okay? So you can use a toothpick or cotton bud twice daily on the lesion till you see erythema or ulceration. After that, the molluscum tends to respond by itself. This is a very good option because it's patient applied. It's not something that they have to keep coming back to you for, like, you know, with cryo and this thing. And even if they get new lesions, they can apply it on those new lesions. The second thing it does is it triggers an immune response. So it clears off much better. Main complaint is it burns like anything when you attach. It's basically we're doing a alkaline burn. So the child will complain of a lot of irritation. So we normally tell them to apply Vaseline around it and just touch the center with the toothpick.
Okay. And when it comes to curettage or any other procedure for that matter, dermatology related, local anesthetic that we mostly use is Prilox. It is a combination of lignocaine and prilocaine. The steps to apply it is clearly written on the box. If you can see, there will be a tube with a sticker. You have to apply the tube on the lesion where you're going to perform the procedure, and then apply the sticker and wait for some time for the anesthetic to act, and then you can do the procedure. Especially since these lesions appear on children, it is very important to use anesthetic, because the child otherwise will have a lot of pain and will be uncooperative. Okay. Now next is genital herpes. You are
One
going
second,
to get
Navneeta, 3 tests. Okay, if you see molluscum in an adult, HIV, VDRL, Hep B, please do it. These are diseases that sometimes you will miss the primary chancre, you will miss something. You don't want your patient coming in late with HIV. You want to do it at baseline, and please take a thorough history. 3 months after their last exposure, again, HIV has to be repeated along with the VDRL. That tends to be the span of the incubation period. Do not miss this out. You don't want, patient coming 3 months later with a positive test report and you've not been treating for so long. Genital herpes, go ahead.
Yes. This is one of those diseases where you have to have a good doctor-patient relationship, because it involves giving a good history. Another thing is exposing themselves to show the lesion. So tell them if they're not comfortable, if the male patient is not comfortable and the doctor is a female, if you have an option of getting another male doctor, well and good. Otherwise, please explain how important it is for you to see the lesion in order for you to give the treatment. And even since it is an STD, even if they say there is no history, you tell them that it is very important for you to know. Otherwise, there is a chance for you to get the same disease again, and the partner also would have similar symptoms, and you will miss it. So it's very important for them to give you a good history regarding that. Incubation period is 2 to 7 days. So what are you going to see? Multiple vesicular lesions will be there. There will be fluid-filled lesions, that is, and they are grouped together. It can even ulcerate also. It is quite painful. There might be inguinal lymphadenopathy in primary infection. The investigation, why I've put an investigation here is because I know Zanxmere and HSV ELISA will not be there in a rural hospital. Some patients might not believe that it is herpes, or if a recurrent herpes infection, they want to get it tested. For confirming the disease, you can tell them, yes, there are tests, you can go outside and get it done. Then you have to tell them that you have to inform all the partners and use a barrier contraceptive. In case of barrier contraceptive also, if there are lesions on the scrotum or labia majora, thighs and all of that, there is a chance of spreading the disease even after using a condom. So you have to tell them that as well.
See, one of the things to remember with herpes is, even if they don't have the active vesicles, they can still transmit the disease. So it is their responsibility to inform all future partners that they have this infection. Okay, because they will have a prodrome where they're actively shedding the HSV virus prior to the development of these lesions. So they have to be warned about this, and they also have to be warned that this is going to come back. One of the things that I found, which is much easier when you swear it's an STI, or you're seeing, if you're seeing something like syphilis, and you just know it's an STI, don't go and ask your patients, are you married? That is a sure sort way of getting the wrong history. The question to ask in this case was, when was your last sexual exposure? So that gives the patient a clear-cut idea that do not be hesitant. If you are nervous, if you are anxious, if you are this thing, patients can sense that and they can feel you judging them. The first thing to do is you have to decide, see, out here, I am not going to be the priest or the parent of this person. You are not their parent, you're not their priest, you're their doctor. Your responsibility is to find out what they have, find out who else they might have infected or got it from, and get them treated. That is your job. You're not here to pass moral judgment on anyone.
Yes. That is why your intention to be very clear to the patient. You have to explain why you are asking it. If you already tell them why you're asking it, they will give you the history, because it is health related. So they will not hide it. They usually give you the history if they feel safe with you. Okay, now what treatment are you going to give them? You're going to give them acyclovir or valcyclovir. Acyclovir would be 400 mg thrice for 5 to 7 days. Valcyclovir would be 1 gram BD for 7 days. Now, topical would be not an antiviral, it is an antibiotic cream, okay, or an ointment like mupirocin for local application twice a day. Now, there is a suppressive dose for people who have repetitive infection for greater than 3 times in 6 months or greater than 6 times in 1 year. So that would be acyclovir 400 BD for 6 months. That time when you're continuously giving acyclovir, you have to monitor creat monthly. Even in diabetic and hypertensive patients also, you have to do a baseline creat before starting oral antivirals, because they might be regular, but they might not be regular, and they might be having nephropathies also. So it is very important for you to be safe and do a creat before starting the acyclovir. Okay. Now, herpes zoster. This is one thing which is very easy for you to diagnose if you examine the patient. But if if the patient is coming telling you, I have chest pain or hand pain, shoulder pain, and you don't examine, you think it is a muscle pain or something, and just give them an NSAID and leave. That is, they might not give you a history of the vesicle, or they must have forgotten, or they don't want to show. You have to ask them, is there any lesion there? You have to make sure you examine, otherwise you will miss this. But if you see the lesion, you will not miss it because it's unilateral. It's only present on one side. It is dermatomal lesion, so it will not be there everywhere. It's just one dermatome area. And skin eruptions will be there, vesicles will be there. It is highly painful. Pain is more than itching. Some people do give a itching history, but pain is the most common. And there might be regional lymphadenopathy as well. So there are two different varieties of it. That is herpes zoster ophthalmicus, where when it is involving the trigeminal division of the ophthalmic division of the trigeminal. So I might be involved in 2/3 cases. So how do you know? By Hutchinson sign. If there is a lesion on the tip of the nose, that is when the nasociliary nerve is involved. That time you have to refer them to an ophthalmologist. There will
So
be
two things,
yeah.
Namita. Not just the tip, even this lateral aspect of the nose. This is the distribution of the nasociliary nerve. So anything on the nose or the lateral aspect
On
of
the
the nose,
lateral, yes.
please go
You
ahead
have-
and send to ophthal. You don't want, this is a preventable cause of blindness because of corneal erosion. So please send them to ophthal. They will require topical steroid applications. If it's very severe, ophthal might suggest an oral steroid. This is combined with your antiviral therapy, of course.
Yeah. And if you're suspecting a slight redness and the patient is having some complaint and you're not seeing the Hutchinson sign also, it's okay. Just refer them to an ophthalmologist. It is okay. Next is Ramsay Hunt. There will be vesicles on the pinna and the external auditory meatus, tympanic membrane, anterior 2/3 of the tongue, because of which there will be ear pain, loss of taste, complaints would be facial palsy and all of that. Now, what are you going to give for all these patients? Previously, we gave acyclovir 400. Here, it will be 800 mg and 5 times a day. So when you tell them it is 5 times a day, they tend to say, should I take it these many times a day? Is it really necessary? Tell them it is absolutely necessary, and tell it's a short course. You have to take only for 7 days. But they are old. They're not understanding when all they have to take the drug. Better to choose valcyclovir, which is only 3 times a day, 1 gram 3 times a day for 7 days. Here also, you have to counsel them properly. Tell them that it is the same virus which is causing chickenpox, but it is not chickenpox. But they should not scratch or touch that area. If there is pregnant women and all, stay a little far from them. If there are newborn babies, also better to stay away from them, and all of those kind of things. And another thing is that tell them that the pain is not going to reduce in this 1 week. You're going to first treat the infection, and there will be pain for some more time. When you tell them ahead of time, that is much better than them coming back and tell you gave me the treatment, but the pain is still there. So you tell all of this beforehand and then give the treatment. So what are you going to give as topical? You're going to give antibiotic cream here, not antiviral. That is like mupirocin for local application twice a day. And for the neuralgia, You can give pregabalin 75 mg in the night for 1 month and gabapentin 300 in the night for a month. If there is continuous type of pain, the patient is telling, no, this is not working, you can start them on amitriptyline 25 mg in the night for 3 to 6 months also. Then you can try topical anesthetic cream because it might persist for a longer duration also in some elderly patients. You can give camphor ointment also for the pain. If all of this is also not working, you can refer them for nerve blocks. It does tamper their daily living to such an extent that you might have to refer some patients like that. Okay. So recovery will be 2 to 3 weeks in young patients, but it will be more than 1 month, like I said. There is a query of immunosuppression. So ask them if you have if are you on steroids, do you have diabetes, you are suspecting some other kind of immunosuppression, get all the tests, that is HIV, HBsAg, VDRL and all of that.
So in this, actually, you just need HIV and sugar testing. Your warning signs,
that is for
warning
STD.
signs for herpes zoster where you should test is any cranial nerve involvement, 1. 2, if the lesions are hemorrhagic. 3, if you're having multi-dermatomal, especially if it's non-continuous dermatomes. And 3, fourth is if it's taking very long time to heal. In these cases, please run HIV, please check sugars. And just because your sugars are positive does not mean HIV is negative. So both tests have to be sent at the same time. In India, diabetes is very common. So that does not rule out HIV because you have uncontrolled sugars. And sometimes this is the first presentation of HIV or hepatitis or diabetes in your patients. If you have a physiotherapist near your center, physiotherapy has a lot of modalities that can reduce the pain. So they have these interferon therapy and all. So that is an option that if you have a good physiotherapist working in your area to reduce the post-herpetic neuralgia. Go ahead.
Yeah. So next, we are going to move on to vitiligo. So we have briefly mentioned about vitiligo while discussing pityriasis. So what are the differences? This history would be a long history. There will be hypopigmented patches, poorly defined borders. Yeah, all these things you will only observe if you closely go and examine the lesion. There will be spotty depigmentation in between. It is here also you have to counsel them. It is genetic. It is there is an autoimmune component to it as well. So when you tell genetic, you should tell them that this is not something which is going to go away once you start the treatment. It's not going to magically disappear. So tell them that it's going to take time. It is genetic. Even if you're on treatment, new lesions can come. It is very important. Otherwise, they will come back to you and tell your treatment is not working. Coming back and telling is one thing, but not coming back to you is also another thing. They will go to another person and they might give another treatment which is not very good for those lesions. So it is very important for you to counsel them what exactly is these symptoms, because since stigma is there, they really want this lesion to go as fast as possible. So explain everything beforehand. So hairs over there might be normal or hypopigmented. Kepner sign is positive. That is, if there is any scratch, if you're scratching or any wound occurs, the new skin which appears might be hypopigmented lesions. There might be other autoimmune diseases like thyroid diseases associated. So that when the patient is already having hypothyroidism, you can tell them what did the doctor tell regarding hypothyroidism, how did they explain it to you. So they will tell it's an autoimmune or whatever they understood about the disease. You tell them this is similar. This all comes under the same family, even if it affects different organs. So then they'll have an idea. They have to continuously take the treatment and tell them this is not going to affect the patient in any other way. It's not going to affect any other symptom. The patient is totally healthy. Especially to parents, when you are counseling, you have to tell all of this. The child is totally healthy. There's nothing wrong with the child. Is very important for you to explain. Okay, now what treatment are you going to give? Topical, mild to moderate. Sorry, that was moderate. Moderate potency steroids you're going to start. And that is in the morning, and night you would give 0.03% tacrolimus ointment. The duration will be based on the extent of the lesion. You can give it for a month, ask them to come back and tell them we'll slowly look at the improvement and see. So in advanced cases, you have to refer to a dermatologist for phototherapy. Tell them options are there. It's not limited. There are so many options. If it is extensive, the dermatologist will will decide on an oral steroid pulse therapy as well.
So, because there's so much stigma associated with this disease, if you feel that lesions are rapidly progressing and all, please always offer your patients the option of referral. Don't be like, oh, this is only, skin and all. It has long-term repercussions in terms of the amount of, I know you're not supposed to give dowry, but that is a reality in rural India. The amount of dowry they have to pay, who agrees to marry them, and stuff like that. So the earlier you start treatment for vitiligo, and we do have a good armamentarium of drugs now. We have things like azathioprine, tofacitinib, but these, unfortunately, I cannot give you a permission to start writing them in rural areas because you have to do a comprehensive TB screening. You have to monitor things like LFT, this, that, peripheral smear, and the quality of tests you're able to do in the rural area. Our first rule is do no harm. So if you plan to start any of these things, please offer your patients that there are better treatment options available. Because see, oral steroid pulse therapy and all is not really ideal. It's been used, but it's not ideal. So if your patients are willing to go to a higher center, do offer them the option of going to a higher center for these treatments. PUVA and NBUVB sometimes in rural areas might not be practical because they have to go to the center twice to thrice a week. Targeted phototherapy, if there's a medical college nearby and they have a dermat department, they will definitely have targeted phototherapy. So that becomes a very good treatment that you can offer the patients. They have to go once a week. So usually they go on a Saturday and come back. That's a good option for them to be referred for. Please do not try doing PUVA, NBUVB topical applications in rural areas. Your patient will come back with nice blisters and come and give you nice galleys left, right, and center because they do have more sun exposure than what we would ideally like. You're supposed to expose to sunlight for somewhere maximum up to 15 minutes, but they tend to spend their whole day outdoors. So if you give something like PUVA therapy, they can have burns. So that counseling is a good long counseling that we have to give about protection from sunlight, use of sunscreens, full sleeve clothing, all of that. So if your OPD is busy, tell them that there are options. Please talk to a dermatologist about them. Tacrolimus, you can actually go up to 0.01%. There are some other peptide compounds, decapeptide and all, which are available. You can message me or something if you have a patient and you're considering those options. We can go into options for treating those lesions if they're not responding to the standard topical steroids. On the face, do not use higher potencies. On the face, we use only desonide or fluticasone. Don't use the higher potency steroids over the face. Similarly, instead of tacrolimus on the face, we prefer to give pimocrolimus. Okay? Go ahead, Namita.
So next would be psoriasis. We had actually put psoriasis picture in the quiz. Surprisingly, a lot of people got that also wrong. So here, maybe it's the picture problem, but when you are seeing a patient with psoriasis, if you see 5 to 6 patients, then you will understand how different it is from other lesions that you normally see. So these are chronic. The patient is going to come with itching, might be there, but they're going to tell them about these lesions that have started occurring on their skin. So it will be chronic patients. Sometimes it would have happened, this would have been happening and it resolved and it's just coming back. So they're worried about this new lesions which has started coming back. Here also you have to tell them it is a chronic problem. You have to keep taking treatment because it is genetic and things like that. If you don't counsel them properly, they are just going to shift from one doctor to another instead of sticking to the regimen and continuing the treatment whenever they're getting new lesions. That is very important. So these are chronic inflammatory hyperproliferative skin disorder. Typically, you're going to see plaques with white scales on top of them. You are not sure, like they might present typically, but they might not. Some lesions might not have any scalings on them. You can do bedside test, which is Auspitz sign. That is, you can just scratch. What will you use to scratch? If you have a glass light, very well and good. Otherwise, please do not use anything that like a pen's cap or anything that you're going to reuse. Okay, like how Mika told, please don't go and touch the patient without sterility. So you have to make sure you're going to use something which you're going to discard. Scratch a little bit, you can see tiny bleeding spots. Most common things that you're going to be seeing is plaque, psoriasis guttate, palmoplantar, scalp psoriasis. Everything else is self-explanatory, but guttate will be the one on the right top corner, which is small button-shaped, small lesions which are going to appear. Which are there are also plaques with scales, but there will be small lesions, and palmoplantar will be just on the palms and the soles, nowhere else. Then there is a good association with alcohol and smoking. So tell them that as long as you're going to continue smoking and drinking alcohol, this is going to worsen. So tell them that you have to stop it. Otherwise, otherwise also it's going to be a chronic disorder, but this is just going to worsen it. Main important thing regarding the treatment is please do not give systemic steroids. That is very, very important in case of psoriasis, because people tend to think it's an autoimmune disease, let us suppress the immunity of the patient. So there will be no lesion. There
One
is
second.
going to be a moment.
One
Yes.
second, Navneeta. In the chat box, can anyone put the single reason why we tell you not to give systemic steroids, oral or IM injection, hydrocortisone, all these things have to be avoided? Can any one of you all write it up in the chat box? What is the complication? This is a neat question. That's the only reason I'm asking you. And while you all are doing that, if you see guttate lesions, please take a prior history of sore throat or pustules on the sore throat, because it's very often associated with streptococcus. Kids who have tonsillitis, things like that, they tend to develop those guttate lesions. In those patients, short course of a penicillin group, ampicillin or augmentin, or a short course of azithromycin can reduce the relapse rate in these patients. And if they're having very frequent tonsillitis with very frequent guttate lesions, tonsillectomy is actually an option for treatment. Eben is here. Eben? 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 If you all don't know, just put don't know quickly in the chat box. Why we don't give steroids. Christina? Omal Jos? Yeah, Christina, tell me.
I don't
know. So it can trigger something called pustular psoriasis, which is a medical emergency. So the patient will require admission. Sometimes they might even require ICU care. So you don't want to cause that. First rule, do no harm. You might think you're doing something of great benefit to the patient, but giving a systemic steroid or applying even these topical steroids for more than 10% body surface area can trigger off a pustular flare. The drugs which we use for pustular psoriasis, which is cyclosporin, retinoids, they tend to be very expensive. Plus ICU stay, it can wipe out a patient's entire savings. So please do not harm your patients. Do not think of giving systemic steroids. If there's the slightest doubt you're not sure it's psoriasis, stay on the safe side. Give an antihistamine, give a topical, do not give systemic treatments. Go ahead, Navneeta.
Yes. So what are you going to give? You're going to start with topicals. Salicylic acid ointment. There are multiple percentages present, but I would suggest you to just stick with 2 to 6%, not more than that, because more than that requires a lot of explanation and things like that. Otherwise, the patient tends to use it a lot of quantities or use it on normal skin. There's going to be burning and other side effects. So first you're going to give 2% salicylic acid. Along with that, betamethasone ointment or clobetasol ointment you can use for local application twice a day. Or you can use a calcipotriol ointment in the night, coal tar ointment in the night. Coal tar ointment is of choice for scalp psoriasis. That is a good use when it comes to scalp psoriasis.
Coal tar can also be used on your hands. And one easy thing to do when you apply coal tar on the hands is apply it in the night. And you have to ask the patient to expose to sunlight in the morning. That is a very good treatment modality for palmoplantar psoriasis, which tends to be quite resistant and your patients are very annoyed with you. One of the drugs that can be safely prescribed in a burn center is apremilast. So you can discuss with us whether your patient is a good candidate for apremilast because it doesn't require as much monitoring. Do not start prescribing again on your own. Again, things like apremilast and all are reserved drugs. So it's written on the package to be used by a dermatologist and rheumatologist, and we need to make sure your patient is a good candidate for it before you randomly start prescribing them. There are newer drugs. Most of your burn centers are not going to be affordable for things like biologicals and all, unless you're working in plantations and you're having some of those plantation owners as your patients. In that case, please pack them straight to the city for the highest end of drugs that they can afford, because they will want that quality of life and those kind of things. So don't sit meddling around. Methotrexate is an option, again, to be done under supervision. Do not start methotrexate on your own. Phototherapy, again, under supervision if you are able to do it in your center. Otherwise, refer. Amrita, you can go ahead with the next treatment modality.
Yeah. So I talked about topicals, and along with that, you have to add emollients like liquid paraffin. Liquid paraffins are available in bottles or Vaseline jelly. The normal ones is more than enough. You do not have to give them any expensive lotions and things like that, and tell them how important it is for them to use it, because you're giving an ointment to be applied in morning and night. Here also another thing, they tend to think that they have to apply it, keep it for some time, and take a bath. Tell them it's not like that. They have to apply it after a bath. There will be concerns like the ointment sticking on the shirt and things like that. Tell them wear a banian, cover it up, and then wear your clothes, and you can help them out with their queries. But make sure you explain to them that you have to apply and leave it on your skin. In the afternoons, you can give the emollients. Now, next is eczema. Eczema,
One second,
yes.
Amrita. There are two questions. One is, should I give methotrexate if the patient comes in pustular flare? Methotrexate is a slow-acting drug. By the time it has action, it's 4 weeks. Pustular psoriasis, like I explained, is an emergency. We do use it in pustular psoriasis after the flare as a maintenance therapy. 2 drugs only, acitretin and cyclosporin. Acitretin never in the reproductive age group. It has a 3-year washout period. Patient may not be getting married today, but we cannot tell what the patient is going to do in the next 3 years. So only post-menopause and adult males who are above the reproductive age will prescribe acitretin. Again, with supervision. Cyclosporin requires monitoring. Blood pressure, create, potassium, all these things have to be closely monitored by starting cyclosporin. This patient will require intensive care. You do not do something like a loading dose of methotrexate and send. You will give something that you can give is you can give a calcium tablet. Very often it's associated with hypocalcemia. You can keep your patient warm. Just like how we transport babies in IMNCA, wrap up your patient because they tend to go into hypothermia, they have shivering. If it's triggered, sometimes it's triggered by an infection, you can give these things. Stephen is asking about tofacitinib. Tofacitinib, please open that thing and see. It can cause reactivation of tuberculosis. So I'm not very, very keen on prescribing it in a rural area where you cannot do an IgRA test to rule out latent TB. So if you can refer your patient, we can get the IgRA done, send the patient back to you, and then you can keep on monitoring. Or if you have a discussion with us and we decide that this is a good drug to start for the patient, you can do it in discussion, but do not self-start tofacitinib. You can lose a patient with pustular psoriasis, in which case they are going to ask you why on earth you didn't refer that patient. You don't want to land in medico-legal soup starting drugs that you're not authorized to prescribe. It would be as akin to starting like thrombolysis for a stroke patient without speaking to someone from neuro. You have to do those in consultation with at least someone who's done MD in medicine. I know dermat seems like it's only skin deep. It's not. The complications, our death rates when our patients are sick are very, very high, especially with our drug reactions and things like pustular psoriasis. We do lose around 1/10 of our patients sometimes in some of these conditions. With regards to Dhwani's question of when do you apply emollients, you can apply your active, which is your salicylic acid, steroid, calcipotriol, quota. You can wait for half an hour and reapply it. If your patients tend to be busy, you can ask them to apply these in the day and the emollients at the night. That is another way of applying it. The good part about putting the emollient over the lesion is that it forms an occlusion and it helps in penetration of the drug. If your plaques are very, very thick, you can ask your patient to apply plastic wrap over it. So this causes increased penetration of the drug. Do not apply any salicylic or clobetasol over more than 10% body area. The systemic absorption is high. It can cause something called salicyclism, which can affect the kidneys. So make sure the body surface area is low when you start these drugs. Go ahead, Namita. Next condition.
Next is eczema. It is redness, discoloration, thickening, and scaling over a particular part of the body. The main complaint that they're going to come here with is itching. Some lesions might be similar to psoriasis, but psoriasis don't tend to have that much of an itching. Here, the predominant symptom is going to be itching. Ask them initially when you had the itching, was the lesion as bad as how you're seeing it now? The itching might have caused them to do more harm in making the lesion bad. So initially they would say, no, it was very small. And afterwards, once I scratched, it became bad. So that is one more history where you will understand, oh, this is something related to an allergy. So the triggering factor, if it is only like the top right corner, you can see it's only on hands. So ask them recently, when did it start? 3 months ago. 3 months ago, did anything change? Did you start using a new detergent? Are you a teacher? Are you using chalk? Did you change? Things like that. You have to ask these questions to ask if there is any, to understand if there is any triggering factor. And the history is a long history because these lesions won't happen overnight. Okay, it will take some time for these lesions to come up.
1 second, Amrita. 3 triggers in rural areas. Cement. Very often there are construction workers. Or there is construction happening nearby to their house with some redevelopment on their own house. This includes both cement as well as woodwork. The sawdust, things like that can trigger it off. Second thing is Parthenium grass. Particularly in South India, they take something known as Narega very seriously. By take it very seriously, it means they go over there and they sit in the grass. Okay. If there is exposure to Congress grass or even the Cosmos plant, it can cause severe eczema, specifically a type of eczema that affects the face and neck, arms, legs. You don't know why this patient is scratching all the time. Covered areas are relatively spared. Please think of Parthenium dermatitis. Show them a picture of Parthenium. They are able to identify the plant. They know what it is. In Kannada, we used to call it Congress ghira. Most people call it Congress grass. But if you show them the picture, they know what it is. Nickel is another cause. Okay, nickel allergies are pretty common, especially people who work in industries. So a nickel exposure, women know artificial jewelry which they wear in their ears, especially silver jewelry. If you're getting, you can see in the first picture the lesions on the ankles. They might be wearing silver piles over there. And on the feet, you need to look. If it's involving the sole, okay, the sole has an instep. If the instep is involved, that is plantar psoriasis. But if the instep is paired and it's on the side, it's an eczema mostly due to the material of their footwear. So you need to look at what footwear they have and they can change it. If your patient can be referred, you can send them to a higher center to do patch testing to find out what materials they can use. Otherwise, just a simple trial and elimination, like say, okay, rubber is not working for you. Sometimes it's not the rubber, it's the pigment in the rubber. So if you change them from, the colored rubber chappal to the plain blue and white bata chappal, they tend to be fine with that. So those kind of small changes, you'll have to look and observe. Dermatology is all about pattern recognition. If you get the eczema around your eyes, it's very common to assume that something is happening with eye drops and all. Please check your patient's hands. It's very often nail paint. They'll apply it on their fingers, or they'll be applying some fancy new moisturizer on their fingers, and then they'll rub their eye like this. Or they may be working at work with nickel, metals and all, and they'll rub it here. The skin is thinner around your eyes. So that side gets affected even if your hands are not involved. Go ahead, Namita.
Yes. Okay. So what treatment I am going to give? First and foremost is antihistamines because their main complaint is itching. You're going to give cetirizine in the night. If the patient is having itching in the morning times also, you can give Allegra in the morning. Tell them about the side effect that is sleepiness. Now, topical corticosteroids, depending on the area. Face, you have to always use a mild one like fluticasone, like how Mika mentioned. Other body parts, you can use betamethasone, clobetasol ointment. Here also, if the lesions are very thick, you can add a salicylic acid ointment also with it.
1 second.
Here
Namita, be a little cautious while applying steroids, applying salicylic acid in cases of eczema. Most of them have very, very sensitive skin. So it's better to apply the steroid and a thick layer of Vaseline over that. And you can apply it under occlusion rather than to apply salicylic acid on these lesions, because if they have irritation, that each scratch, each cycle is not going to go. Second thing, check what ointments you're giving. Plain coconut oil, plain Vaseline, meant to be safe. These moisturizers which have 20-30 different ingredients, eczemas, you should avoid them.
Yes, you can give plain liquid paraffins or Vaseline jelly. That would be more than enough as an emollient. And infections are very common here because they're using their nails to scratch these lesions. Here itself on the top left corner, you can see that there is a bleeder there. So that is because the patient was scratching. So you check for any oozing or discharge from that eczematous area. If it is there, should not give topical corticosteroids. Give them antihistamines and give them a course of antibiotic for a week. Tell them you have to come back after a week. I will check on it and then we'll give you another treatment for the lesion. Tell them it's now for the infection. On the next review, we will start you on the treatment for the patch.
So one of the things you can do is wherever you're seeing these open areas, you can give them an antiseptic cream for that area. Something like fusidic acid or mepirocin or soframycin. Surrounding area, you need not give an oral antibiotic. It's not very extensive. But if they're having large involvement, give them something, especially a penicillin group works well for this. Doxycycline is another antibiotic which works well. Surrounding areas, you can still give a topical steroid. The main reason why you have atopic dermatitis or eczema is they have a genetic defect in their skin barrier, which one causes a lot of fluid loss from their body. And second thing, it allows things in the environment to come in contact with their immune system. So establishing a barrier is important. Now, what happens is most people go and apply the moisturizer 20, 30, 40 layers and it does nothing. You have to apply moisturizer on wet skin. So soak the skin, wipe the skin with a wet cloth and apply this. Now we tend to think of these things as an infection, but what happens is it's because of the defunct barrier that you're getting those pustules. So patients tend to apply Dettol, something else to clean the skin aggressively, a lot of soap. These kind of lesions, cleaning with plain saline, plain water is good enough. You don't need to aggressively scrub that skin. The more you try to disinfect that skin, the worse it tends to become in an eczema. Antihistamine is your main treatment. Give it twice a day, give it thrice a day if you need to stop that patient from scratching. Ask them to apply ice packs instead of scratching. That's one of the very effective ways of reducing the itch in these patients. Just applying a cooling ice pack helps a lot. And if you can break the scratch itch cycle and keep them on emollients, coconut oil, or moisturizer for a long duration after that, your recurrence is going to be low. Go ahead, Namrita.
So next is going to be scabies. This is another very, very common thing that you're going to see in your burn center or any other rural hospital that you're working. It is caused by Sarcoptes scabi. The history is going to be a very classic one. That is nocturnal itching. Whenever they might not say nocturnal itching, they'll just say itching. But you're suspecting scabies means you specifically ask. Even if you're not suspecting scabies, also ask them when exactly. Is it throughout the day or just in the night, just in the morning? When exactly is it itching? So they will tell you that it's only during the evening and night times. Then where exactly is it itching? They will tell initially throughout the body, but specifically is it itching anywhere more than the other parts of the body? They might tell you between the fingers, groin and all of that. These mites can survive outside the body for 24 to 36 hours. So explaining them that not just the treatment, the other hygienic practice is also very important. So you have to tell them what all the child or the patient is using. You have to make sure all of that is also clean. And you ask her any history, since how many days it's there. Did the patient travel anywhere? Is the child staying, or the adult staying in the hostel? Anyone in the family or any friends are suffering from the same symptoms, etc. So when you're examining, you will see these classic burrows, raised brownish linear or serpentigious papules present on the web spaces or between the thighs and the groin area and all of that. And there will be a lot of excoriation marks as well. Mainstay is 5% permethrin cream. You can give, 1 second, yeah, thank you. So first thing that you're going to give is antihistamine, that is cetirizine in the night. Then you can give it for a week because we will repeat the treatment after a week. You're going to give 2 tubes of 5% permethrin, single application. Tell them to apply 1 full tube for the entire body below the neck and keep it overnight and ask them to bath in the morning. That is the best way. Here also, otherwise they'll keep it for some time and then wash it off. Then you tell them the second tube is for the same day next week. If they come on a Monday, tell them tonight you're going to apply, next Monday also. If they're not understanding, tell them the date also. Ask them to repeat. Anything that is confusing to them, you explain and ask the patient to repeat it back to you to make sure they understood it properly. So you're going to repeat after 1 week. Then you're going to give tablet ivermectin 12 mg, 1 today, again a week later. So next Monday, like that.
One quick caution, ivermectin cannot be combined with a lot of medications, okay? It causes QTC prolongation. So just be careful, and patients who are on antihypertensives, patients who are on antipsychotic drugs, we tend not to give them ivermectin. Now, unfortunately, like the site where I've seen the most cases has been in a juvenile detention center. A lot of, not so much in the girls' juvenile detention, a lot of the boys in juvie have psychiatric comorbidities. In this case, permethrin is safer. Second thing that you need to remember with permethrin no, is your patient is not going to understand what you say the first time you tell them this. So it's going to be, you tell them, they repeat something wrong, then you correct them, they repeat it again, and this goes on. Another common mistake, they apply it everywhere, they wash their hands. It doesn't go. They have to leave it on their hands. So tell them to, then they will ask you, you say, no, you can't wash your hands. They say, when should I eat? So you tell them, please eat your food and then do all these applications. And that itching is not going to stop for 1 month. Scabies might will die and everything, but it remains in your skin. The Skybala remains in your skin. So antihistamines at least 1 month, and tell them it is going to itch from a month. Treat everyone. They'll say, but my daughter doesn't have, my wife doesn't have. Does not matter. Tell them it is like an invisible little mosquito. If you apply Odomos on you, it is going to go and bite your wife. That's all.
So you
Both
have,
tubes.
yes.
So some people are saying gamma benzene benzoate is available. Is that fine? Is it important to procure permethrin? I find it's important to procure permethrin because you can apply permethrin from the age of 2 months. Okay. Gamma benzene benzoate, because of its high absorption, when you give it in children, you can precipitate a seizure. So permethrin is better. Second, a single application of permethrin is usually enough.
Yeah.
Unfortunately, most patients don't apply it properly the first time. So 2 applications at least you can be kind of sure that it's out and gone. Do we need to give ivermectin and permethrin? Typically no. I tend to use ivermectin when it's an outbreak in the hostel. You can give one tablet to everybody, because in the morning if everybody has to apply this, wash it off and all, in hostels where they can't reach unreachable areas, ivermectin tends to be better for people living without support compared to permethrin. But again, be careful for old age homes where they're on like psychiatric medication, things like that, sedatives, sleep medication. It can have drug-drug interactions. You do not have to give both. You can give one. The both tends to be people being cautious because people just do not apply permethrin properly. Washing clothes is important. They'll do all this and then they'll sleep in those same clothes. It can live for 3 days. Anything they have used in the last 3 days needs to go for wash, including socks. This is something that my patients tend to forget. They forget to wash their socks. They keep wearing the same socks and then you'll have the lesions localized on that area. Complications wise, kids tend to have nodular scabies lesions on the scrotum, especially male kids. In that case, after you have completed your treatment regimen, call them back and you can give a short course of topical steroids only on the bumps. Do not make it a habit to give everyone the topical steroid. They find topical steroid makes me nice and comfortable. They will apply it for anything, everything, including their face. So they have to be told that that topical steroid cannot be used more than a week. After a week, that tube has to be thrown. Okay. So these are the complications you can expect. Very often if the lesion, skin is broken, if they have impetigo and something sitting on that thing, permethrin will not work. Crusted scabies, again, it does not work very well. In that case, we do combine ivermectin with permethrin for better clearance of the lesions. Do look for diabetes and do look for leprosy. If you see a lot of crusting of the lesions, it is very often indicative of either neglect or a sensory loss. Because normally when you scratch, you dislodge that crusting. If it's building up, that means you're not able to feel it. That's why there's a hyperkeratosis over there. Go ahead, Namita.
Yeah.
Next slide.
So next would be hair fall. You're going to get a lot of patients with hair falls. So what is telogen efflume? It's one type of hair fall where there is rapid hair loss after they have had an infection or any severe stress or change in their body. So this is basically thinning around the top of their head. When the patient comes with a history of hair loss, please go and check their heads. It gives them a sense of satisfaction that the patient have come with something and you are examining the patient. If you're just going to give them an a multivitamin tablet and send them, they are going to be very unsatisfied with it. So it's okay. Tell them to untie their hair. Just look through it, where exactly the thinning is, and all that is all that you have to do. And
1 second, Namita. Can anyone in this group, maybe is Omal there? Omal Rose?
Yes, ma'am.
Can you tell the difference between the top picture and the bottom picture? What is the main difference that you see? If you don't know, just straight up say don't know. Don't worry. Not
I don't
judging
know,
you.
ma'am.
Okay, so in the top picture, all the hair is thinned out. But in the bottom picture, you can see the widening of the midline. The top picture is classically what you see in telogen effluvium. That is the entirety of the hair will thin out. Now, if you take the hair, now see what I'm doing. I take a bunch of the hair in my hand and I give a good tug. Now, if I get strand and I do it here, I do it on the sides in at least 10 different locations, and I get hair in my hand, that means the telogen effluvium, it's either nutrition or they've been pregnant or they've had a surgery or some major illness. But in the second picture, you can see that widening happening on the frontal area. That is hormonal. You usually see it in postmenopausal females, people with a thyroid disorder. Males tend to have the androgenetic alopecia as a recession from here as well as the crown. But this is how androgenetic alopecia actually looks in women. So don't confuse the two. The second one requires hormonal evaluation. It requires lifelong treatment. The top one, easily resolvable hair, is going to come back with ease, with a lot of ease if you just treat the patient properly. Find the deficiency, correct the deficiency. It's important. Continue, Namita.
Yeah. So you're gonna look for quite a few things. First, initial common thing that you're gonna look for is anemia and vitamin B12 deficiency. See for knuckle pigmentation. For anemia, you can check the HB and other vitamin deficiency levels. If you have it at your hospital, well and good, or you can ask them to get it on outside and come back also. And if the vitamin B12 levels are low, or the patient is pure vegetarians, you assume the vitamin B12 levels are low, and you can give the 1500 microgram orally stack dose, or you can tell them to, if they are non-vegetarians, tell them that all the non-vegetarian foods contain B12. So ask them to increase that. Ask for history of any pregnancy, major illness before the symptom. This is very important. So when you're finding what the cause is and telling them this is exactly why this hair fall is happening to you, that itself will be a huge relief to them. They just want to know why this is happening. So if they are going, and tell them that if you're going to get tensed because of the hair fall, it's just going to cause more hair fall. So don't be tensed. We're going to treat it. It's going to be fine. Just let them know that. It is good to give a biotin supplement, but it is very expensive. Very alternative method is to tell them to eat 2 eggs a day. Nutrition is very important.
One
them
thing,
if you have
a lot of these gym bros, no, are on these protein supplements. Okay, they tend to do weird things. They'll have raw eggs and all. Raw eggs inhibit biotin absorption. You tell them the egg needs to be cooked. Second thing, that second picture you're seeing, which is female pattern hair loss, or the the androgenetic alopecia. One of the newer correlations we found is with the use of artificial protein supplements. So they contain whey proteins, which are branched chain amino acids, which can cause a metabolic imbalance. Okay. So make sure your patients are not on these supplements. Hair fall, small problem. Metabolic diseases on account of this, big problem. Not worth the physique to get diabetes at 30. Okay.
Yeah.
Go ahead, Namita.
So nutrition is very important. If you have the time, ask them regarding their diet. They are going to be having a very deficient diet in some way or the other. So explain what a balanced diet is. All of that, this will help. Even if you are not finding the cause of it, giving them a good nutritional advice itself will make a huge difference in their hair fall. Now, next is another type of hair fall, which is alopecia areata. A lot of you guys got this right during the quiz. But one thing that you have to be very careful of is distinguishing this with the Tinea capitis. So examination here also, examination comes into play. Ask about itching. Are you sure there is no itching? Is there any other lesion similar to this, or anything else in any part of the body? And things like that you have to ask. Here, it is a very smoothless hair patch. That's it. There'll be no other complaints. They would have noticed it while looking at the mirror and things like that. There'll be no itching. No, there might be little erythema. That's it. If you have KOH smear and you are in doubt whether it is alopecia areata or a tinea infection, please do get it done. It's okay to do that. And if you do not have, and it's borderline 70% you think it is a fungal infection, give a topical antifungal for quite some time. It is fine, but
you can take a picture actually. Take a good picture. Your cameras are higher resolution. Take a good picture. Put it on that Joint Academics group. We will show you why it's not a fungal infection. But if you all don't open your mouth and you all don't ask us things and you all don't discuss, no, you will never end up learning the difference between them. And you will always be in that sense of panic. And put it on the group. The reason we are asking you to put it on the group is so that other people can also see that lesion and they can also learn the difference. Because now you've seen the case, I have responded to you personally, you now know the difference. But nobody else has learned. We are not there to beat you up and all. Sometimes we might ask you for a little more history because those tend to take our diagnosis in a particular direction. Okay, so just take a good picture, put it up, take it without flash, especially on the scalp. Otherwise, the glow from the scalp with a nice coconut oil, which half of India uses, we will not be able to make out where the patchy hair loss is. You can also see tapering of your hairs towards the ends of the alopecia lesion, and the hairs around that thing tend to be loose, so they come off in your hand. That center part is completely cleared. If you're seeing erythema, one of the common rural remedies for alopecia areata is to take some garlic and all and nicely apply it on the scalp. It works, okay? Doesn't mean you should prescribe it, but it does work because it acts as a counter irritant, so it modifies the immune response. There are other ways of doing this. We use things like DPCP and stuff like that, anthralins and all. But you don't need to do that in your center. Intralesional steroid, if there are 1 or 2 patches, is a very good option. 5 to 10 mg per ml once a month. So 10 mg is what you get. You get 10 and 40. Please don't use 40 for this. 40 is only for keloids. 10 mg per ml, you dilute it to 5 mg if it's on the beard area. Sometimes you might even want to do 2.5 mg if the skin is very thin. So just ask us before you down-regulate the dose. Don't give a higher dose than necessary. If you feel the skin is thinned out, atrophied and all, do not give the steroid injection. That means they've received it. There is a small possibility that this might have been a scarring alopecia, which is something you don't want to miss. So if you feel the skin is looking a little abnormal, it's not looking like shiny, smooth skin, please ask us before you give the steroid injection. If you miss a scarring alopecia, the hair will not come back. If you treat alopecia areata, it's non-scarring, hair will come back. Telogen effluvium, anagen effluvium, and alopecia areata are non-scarring. Androgenetic alopecia in the late stages can become scarring and the hair might not come back. They've lost their entire head of hair and then they wake up at the age of 50 and they come to OPD and say, ma'am, now I want my hair because I'm having midlife crisis. That time we can't help anybody. The earlier we start treatment, the chance of getting the hair back is good. Alopecia areata, hair comes back. But if you have confused this alopecia areata and like mistreated someone with, say, discoid lupus erythematosus or lichen planus pigmentosa, where there are changes in the skin, you're seeing erythema, you're seeing scaling, and you've decided to go ahead and do this, that patient's not getting his hair back and it's going to spread. And they come late to us, we can't help them at that stage. It requires intensive immunosuppression to treat scarring alopecias. Moreover, you might miss something like lupus, which you don't want to do. Go ahead, Namita.
So, why we stressed upon the fact that you have to make sure it's alopecia areata is you can see the treatment. It is just steroids. So, it is always better to confirm because by any chance, if it is an infective cause, it's just going to make it worse. So, that is why we have to make sure that it is what we think it is and give the right treatment. So, that's it, guys. We both are smiling happily, thinking you guys got something out of the class and will not be relying on those combination ointments that we mentioned in the beginning. Thank you so much for this opportunity.
Navnita, 1 second. Christina, are you there? Is Christina here?
Yes, sir.
Okay. You can take a look at the group and the picture she's uploaded. I want you all to notice some things that will help you in the diagnosis. Starting with a history. She said 30-year-old male, itchy lesions for 3 years. This means that this illness is a chronic illness. So I know that this is not something that is acute. It's less likely to be something infectious because it's going on for some time. He has taken multiple treatments, but it's not decreased. Starts as a fluid-filled lesion and then progresses. Multiple treatments are not decreased. When you take this treatment, Christina, see now I know the diagnosis. But for y'all, it's important to ask them when they take that treatment, does it go down? And then does it flare up again? Because that will tell you that this thing is a recurrent phenomenon. So I'm going to assume that this patient has these vesicular lesions. They become crusted, they become eroded. He usually takes a topical steroid because that is the usual treatment. Even if they've not done anything else, they'll put that combination cream which has a steroid. It will come down with that. And then it flares up again on exposure. Now, the most important history that I want to know is what you've given is that he's a Mason by profession, which means he's coming in contact with Christina.
Yeah, cement.
Cement. So that means he has a chromium allergy. And as long as he comes in contact with chromium, he is going to keep developing these lesions. Now, this is something that is a little hard for us to do as bonders, but it's important to find out the support networks in your area. Some of those who work with NGOs, this is a little better. Places like Sitlingi, Kudlur and all, they have these employment cells. So maybe you can, retrain them or put them in contact with these employer people who will give them alternative operations. So maybe a tailoring workshop or something like that, just short-term thing, because just getting him away from cement is going to improve this man's life significantly. He keeps going over there, he's going to have flare, he's to miss work, his net income is going to be lower. So counseling your patient, if they have passed maybe if they passed 10 standards, some driving class, something like that, just that simple change in occupation, easier said than done, is going to be what is going to improve. When he comes in like this, yes, antihistamines, topical steroids, mainstay of treatment. If it's very extensive, there are a lot of pustulation, things like that all over the body, you are going to want to give a systemic steroid for these kind of conditions. But just talk to us once before you start an oral steroid, because you have to make sure there's no infection. You need to take a CBC. You can check sugars also once, check the blood pressure once before we think of starting an oral steroid. There are drugs like azathioprine, if it's very extensive to use to treat this condition. That again in discussion we can decide whether, because it requires again blood monitoring. If the patient can't afford monitoring, then azathioprine is not such a great drug. Tofacitinib is not such a great drug, because these drugs tend to cause reactivation of hepatitis B, C, which we're not screening for. And even if we screen, we have a rapid test. We don't have a core antigen test. So that makes it a little dangerous. You don't want this patient to develop fulminant hepatitis over a cement allergy. Barriers are important. Wearing full sleeves, full boots, things like that can actually, if the patient's unwilling to change their occupation, if you ask them to wear knee-high boots, get like a full length, like, a boiler suit kind of a thing when they go to work, it can protect their skin from coming in contact. When they take off their clothes, they should take it off and they should not re-wear those clothes, because very often people with allergies, especially these Parthenium allergies, they'll have worn some salwar or they will have worn the sari. They'll hook it behind the door and they'll re-wear that. When they wear that, the dust, the dirt, the pollution is coming back on contact with their skin. Even if it was on the outer side of the skin, it comes on the inner part of your of the clothes and onto your skin and makes it worse. People who have these allergies, you need to tell them to dry their clothes indoors and not outdoors, because pollen tends to sit on clothes. Is that helpful, Christina?
Yes, ma'am. I had to add one more history. He told that after taking itraconazole for 4 weeks, in the last photo, in the palm there's a clearance. He told that it decreased after taking
Did you
itraconazole,
give an
and
ointment with that? Did you give an ointment with itraconazole?
Yes, ma'am.
So it's
The
actually
benefit
not your
for this term.
itraconazole. So most of your antifungal creams come in an ointment base, which act like a barrier. So that is actually what is improving your patient and your antihistamine combined with it. This does not look like classical tinea per se. Neither the foot, because can you see on the foot? I wanted to look at the foot lesions clearly. There are quite frank papules over there. You don't get papules in tinea. Those papules are what we call like lichenification. If you see, it looks like a more hyperpigmented, almost like, when we say violaceous, you think violet. You have to think of violaceous as something more like India ink, like a very dark bluish black pigmentation. So those lichenoid papules, raised papules on the thing, means that it's a sign. Those are called prurigo nodularis, that this is more of an allergy rather than an infection. You will not see those nodular lesions, the papillonodular lesions which you're seeing on the feet in the case of tinea. You can, of course, have a secondary infection of tinea, but if you look at the hands also, it's this portion, it's the fingertips. These are the portions which come in contact with the cement. So getting your patient a pair of gloves and telling them when they remove their gloves also, they have to be careful. Otherwise, they'll pull off the glove by putting their thumb inside. So again, the allergy will worsen. They have to pull off the gloves this way. Those kind of simple measures will improve your patient's life considerably. Apply a good dose of Vaseline before going to work. If you look at the hand lesions, you can see these small, deep-seated vesicles. That is called a pompholyx. That is again very classical of an allergy. But yes, pompholyx can occur in the case of tinea when the patient is allergic to the tinea. So tinea medium, tinea pedis, you can have these kind of deep-seated vesicles. But Given the nodularity of the other lesions, I would go in favor of a contact dermatitis to chromium.
Thank you so much.
Anyone else has any questions?
Nika, just 1 second. Before we go into the any more doubts that they might have, we would just like to let you all know, could you please fill the feedback form, which has been put in the chat box as well as in the WhatsApp group, because filling these forms help us improve our next sessions, and also let us know what you would like to know about, like, for the future sessions. So please do fill the forms, and we will also have a doubt clearing session. So just take 2 minutes to fill the forms and you can come back with any doubts you have.
Yes, please use this 2 minutes to write your doubts in the chat box, and then we can discuss it after that.
Now, would anyone like to, does anyone else have any more other doubts that they would like to put up or ask Mihika?
I think one topic we not covered is urticaria. Just one thing, I know in EMED you all are taught state avel hydrocot, and that tends to be the tendency in rural areas. In rural areas, the most common cause of urticaria is not some exotic thing like shellfish. It is usually an infection. Please take history. Does your patient have fever, cold, cough, burning, micturition? If they have that history, please don't hit them with a steroid. Go ahead and give Avel. No problem. Give Avel. Treat the infection. Immediately, everything else will subside. Those tend to be your acute urticarias, and treating the infection will just sort it out. If you give the steroid, that poor patient who would have had viral URTI for 3 days will have viral URTI for 3 to 4 weeks, and urticaria will sit with the viral URTI for 3 to 4 weeks while you struggle with both of them.
Yeah, one more thing, the post test will also be put up in the group. Please don't forget about our Alumni Association merchandise prize. So make sure you go back and write down your answers, and we will be announcing the winner shortly. So I will be putting up the link in the discussion group after the class, and make sure you guys go back and fill it. Thank you.
Thanks, Navneeta.
Are there any more doubts? Okay.
Yeah, Christina.
Yes, Christina.
Ma'am, in our bones, in the bone center for Tinea, we usually give dexamethasone injection with Avil. Is that
Please do not. Any infection. See, if you're finding dermat very confusing, no? One of the basic things that we used to tell ourselves as bonders is step 1. Is this an infection? If it is an infection, treat infection. Do not suppress the immune system. Step 2. If it's not an infection, is it inflammatory? Or and is it an acute inflammation or a chronic inflammatory condition? So something that is acutely worsened, this thing, you can give a short-term steroid, like an acute eczema, something like that, urticaria, which is no infection preceding it, you can give a steroid. But anything that is tinea, anything that is a bacterial infection, please do not give a steroid. It makes it almost impossible. They come to us after 1 month, 2 months of treatment. It's almost impossible to treat them. Third thing, if you want your patient to avoid the DEXA, because sometimes your patients are very arm twisty, things that you can give them as injections. You can sort out the immune issues, because immunity is low, tinea doesn't clear. So check their B12, hemoglobin, those kind of things. Supplement them for those. Give them the vitamin D injection if they've not taken it in the last 6 months. Give them antihistamines. No problem in giving them antihistamines, but do not give the steroid left, right, and center. We will, what we're planning to do is we're planning to make a list of drugs that you all need to have for each condition and give that to you all. So I know it's a little hard. Some senior journalists, some senior non-journalists are very stuck in their ways. and they feel like some things have worked for them for many years. In that case, at least you all will have some data to back you all up, saying that this is what they have said, this is what the dermatologist has said. Stand up for your patients. It's better not to harm your patients than to do something that this thing. Things like recurrent dexamethasone injections and things like that, no, they cause HPA axis suppression. The rural population also is very malnourished, so you can trigger off osteoporosis, necrosis of the neck or femur. Because today they'll come to your center, take one dexa, next day they'll go to another center and take one dexa, and it becomes the patient becomes steroid dependent because they're reliant on the steroid. Then they develop acneiform eruptions, they develop topical steroid damage faces. It becomes a very vicious cycle to break. So no steroids if there's an infection. That's like baseline rule. No steroids if it is psoriasis. If you've ruled out psoriasis and you've ruled out an infection, yes, steroids have a role. But see, even in a case of vitiligo, something like dexamethasone is not going to help. It requires like more of a topical therapy or a pulse therapy. Something like azathioprine and all would be much better in those cases than giving injection dexamethasone. Dexa and all have a role in certain conditions like pemphigus and all, but those are not conditions you're going to manage in your center in the first place. Those are absolute and essential referrals. Even SLE, things like that, yes, we do give steroids, but again, under monitoring. Another condition, don't miss out, systemic sclerosis, please, please, please do not give a steroid. You will precipitate renal crisis. That will cause complete shutdown of the kidney. Do not touch steroids in a case of systemic sclerosis.
Thank you, ma'am.
A lot of you guys are sending thank you notes in the comment section. Would be really helpful if you guys can fill the feedback form, because that will help us in improving the sessions much more. So please do. These notes are really helpful. We are really happy that you guys love the session, but make sure to give those in the feedback form as well.
Any other doubts? Tara, I think we can close then.
Yeah. If there are no other doubts, we will close this session. I would like to thank Mihika and Navneeta for a wonderful session. It was very interactive and very patient-oriented class. I'm pretty sure everyone took away a lot from this class. So thank you so much. And also thank you all for joining. We hope to see you all in the next class. And kindly do fill the feedback forms. And also please don't forget to do the post quiz. Thank you.
Thank you so much, everyone.